It is really my pleasure today to introduce Karsten Roberts. Karsten is an adult critical care and clinical education specialist at the Hospital of the University of Pennsylvania in Philadelphia. He's been an RT for 16 years, graduating from Boise State University in 2006 and earning a master's degree in respiratory therapy leadership from Northeastern University in 2014. He's also a fellow of the American Association of Respiratory Care, very involved in both the AARC as well as the Society for Critical Care Medicine. Really, help me join in saying welcome to Karsten to be able to have this conversation, provide insight on weaning strategies in the ICU for your ventilated patients.
Thanks, Winnie. And it is my pleasure to be here and present on a topic that I feel very passionate about, and I think that we all as respiratory therapists should take ownership of, because this is really where, when we start having conversations about value-added respiratory therapy, this is where we come into play, and this is where we really show our abilities as therapists to assess and make recommendations. And actually, and if you're working in an institution where your weaning strategies are protocolized, then you really have the ability to shine and affect patient outcomes. I have no conflicts of interest, none real or perceived, and there's no specific devices in this presentation, but if I were to mention any devices, they were only for purposes of the topic. Let's see. So our objectives today are to describe spontaneous breathing trials and to discuss weaning from mechanical ventilation, and ultimately the discontinuation and liberation from mechanical ventilation. So I think it's important to keep those three things separate. The spontaneous breathing trial in weaning and discontinuation of mechanical ventilation are all kind of separate things, and ultimately liberation even is different, because liberation comes after you've discontinued mechanical ventilation. So just to begin, I want to point out that when it comes to, just as I said in the first title slide, respiratory therapists are really important in demonstrating improved patient outcomes and decreasing the duration of mechanical ventilation when we use protocols. I think it's also important to note that mechanical ventilation is a life-saving intervention, but I always highlight with our respiratory therapists here and with students and new respiratory therapists that it's our goal from the very beginning of mechanical ventilation. As soon as that tube goes in, our goal should be to get the tube out. And so even though we save people's lives using mechanical ventilation, we want to avoid complications, including prolonged mechanical ventilation and delirium and such that we'll talk about throughout this presentation. So this graph comes from an editorial that was published in Respiratory Care back in 2017. It was an editorial about a study that was done in a pediatric ICUs regarding weaning from mechanical ventilation, so it just demonstrates it doesn't matter if you're an adult critical care therapist or a pediatric therapist. We're all kind of working on the same timeline in terms of escalation and de-escalation of care. And the very first time that we should even start thinking about weaning from mechanical ventilation is once we've kind of reached this plateau phase of acuity. So you have this really big spike when the patient's really sick, and then you kind of have this plateau. And as soon as you kind of get as out of trouble and you've kind of plateaued in the patient's care, this is when we really want to start thinking about de-escalating care. So we should then move on to increasing the frequency of trials of lowering support. Now, this doesn't mean a spontaneous breathing trial. It just means lowering ventilatory support. So however you do that, whether it's changing the PEEP or whether it's changing some other setting on the ventilator that de-escalates care, you should start doing that and increasing the frequency at which you do that after that plateau phase. And then once a patient is optimal for SBT candidacy, and we'll talk about that in the next couple of slides, what that looks like, that's when you can actually start to assess whether they're ready for a spontaneous awakening trial and a spontaneous breathing trial. So from the very beginning of my career, I was always taught and always understood that if a patient were to fail one trial of spontaneous breathing, they should then have the amount of ventilatory support increased back to wherever they were prior to the beginning of that trial. The nurse can work on changing sedation, and you can work together on a plan for then trialing spontaneous breathing again the next day. Typically, there's a 24-hour delay between of the SBTs, and then really trying to, once a patient passes SBT, you want to make sure that they're extubated, as quickly as possible, and then have this systematic approach to difficult prolonged weaning. So this number 6 on this graph is a totally different presentation, because you could talk for a long time, for at least an hour, about what it's like to assess patients and treat patients that are prolonged. And I'm not talking about LTACs, I'm talking about patients that are still in acute care, critical care, but prolonged mechanical ventilation, which is one of the things that our MICU here at the Hospital University of Pennsylvania is really good at doing, is managing patients on prolonged mechanical ventilation. So this graphic may look familiar to some of you. It's from the Society for Critical Care Medicine, the ICU Liberation website, and many of us are familiar with the ABCDEF bundle. This is the Wake Up and Breathe protocol. It comes from Vanderbilt University in Tennessee, and the SCCM has kind of utilize this and put this out there for us to reference when we're talking about how patients should be weaned from mechanical ventilation. And what this part of the bundle looks at is the combination of SATs and SBTs. So every 24 hours, as I mentioned, the nurse should be thinking about what the criteria for weaning sedation is. If the patient is off paralytics and they didn't have a recent myocardial infarction, things like that, then they're probably safe to screen for SAT. And as the SAT is performed, sedation is weaned. The nurse is looking for what's the ICU CAM score, anxiety, agitation, pain. That's delirium, but rather the RAS score, and we'll talk a little bit more about RAS here in a minute. But you're looking at anxiety and agitation. You're looking at their respiratory rate and oxygenation status. And if they fail any of these, then the sedative should be restarted at half the dose, and a trial of sedation weaning should take place at a later time. So that's the nursing aspect of it. But then when it comes to respiratory care and they've passed an SAT and you're able to wean sedation to a point that the patient is comfortable and not agitated on the mechanical ventilator, then you can look at criteria for spontaneous breathing trials. And that includes that aspect of little to no agitation, and oxygen saturations greater than equal to 88%. Now, some of these numbers may vary according to your institutional policies, but these are the generally accepted guidelines for for SBTs. Once a patient is past an SBT, then you're starting to consider extubation. But if they fail an SBT for the criteria listed here, or again, whatever other criteria maybe your institution uses that aren't listed here, then you would return them, as I said in the previous slides, to full ventilatory support until they're ready to then move on to another trial of spontaneous breathing, maybe the next day. So again, coming back to this information from the Society for Critical Care Medicine, the data shows us that the combination of the SAT and SBT has led to decreases in mechanical ventilation of 3.1 days, and the necessity of tracheostomy and delirium and the risk of delirium also decreases at a statistically significant level when you use SATs and SBTs paired together. You have a reduction of the ventilatory time, and you're preventing prolonged mechanical ventilation. And really, again, like I said previously, any prolonged mechanical ventilation beyond 4 days can lead to increased hospitalizations and length of stay, and ICU length of stay also increases when mechanical ventilation is prolonged. So light to moderate sedation is ideal to reduce anxiety and agitation. The patient should be able to interact with the mechanical ventilator seamlessly. There shouldn't be asynchronies. And then what we're really starting to see now as time progresses, heard a lot about this recently with COVID, is you're starting to deal with post-traumatic stress syndrome and other mental health issues that patients face post ICU stays. There's a number of books that physicians that experienced ICU stays have written about their experience and about the trauma that is involved in that, even from a medical perspective. So deep sedation has been found to reduce 6-month survival. So again, the really important thing is to remember that we as respiratory therapists are working together in concert with our nursing colleagues in order to wean sedation and to get the patient off the ventilator as quickly as possible. But it also profoundly decreases the risk of mortality and traumas and other psychological distress that patients may experience from prolonged mechanical ventilation. Again, everything that I'm talking about and reviewing right now can be found on the Society for Critical Care Medicine's website, and is a part of the ventilator liberation bundles. I talked about this a moment ago. And just going to quickly go back to the Richmond agitation sedation scale. I found that sometimes respiratory therapists aren't as familiar with this scale or have not seen it or used it. So I always like to kind of review this when I'm talking about SBTs and SATs. And this is really where the idea that a patient should be minimally drowsy. You don't necessarily get a patient that's alert and calm on mechanical ventilation, because it's still not awesome to have the tube in and having pressors added to your lungs. And so you want the rascal to be somewhere between 0 and -1, and then you use the rest of the scale as an assessment as how close to 0 to -1 the patient actually is. So we'll get into some of the literature here. There was a lot of this, the basis of the SCCM guidelines, or the SCCM liberation, comes from a randomized controlled trial that was done, published in the Lancet in 2008, where 336 mechanically ventilated patients were either randomized to daily sedation awake trial followed by an SBT versus the usual care with SBT. The primary endpoint of this was breathing without assistance. And as far as 28-day outcomes go, the patients spent in the intervention or in the control group spent an average of 14.7 days on, or excuse me, say that backwards again. The group patients in the intervention group spent an average of 14.7 days vent-free, whereas the patients in the control group spent an average of 11.6 days ventilator-free, which was statistically significant. And again, that's where that data of the 3.1 days mean difference comes from. ICU lengths of stay were decreased to a statistically significant level, and hospital length of stay also decreased. I'll just really quickly point out that a couple of the authors on this, call them out specifically. Tim Gerard from the University of Pittsburgh. I'm currently working with Tim on SBT guidelines for the AARC, and then Barry Fuchs is the medical director here at the Hospital of the University of Pennsylvania, and Tim was the lead author on this, and Barry was here as well. And I will tell you that Dr. Fuchs is very, very passionate about this literature and how we conduct ourselves in our medical intensive care unit and across all of our ICUs in our health system. So let's look at some clinical practice guidelines, because it's not just that one trial. There's a lot of data that exists on this information that I'm presenting. This is from CHEST and ATS. There was actually a couple of clinical practice guidelines that were partnered together, so I'm going to go over both of them. The first one was published in CHEST back in 2017. And before I get too deep into this, I just wanted to really quickly review what we're looking at in this question. So at the beginning of doing a clinical practice guideline and trying to understand where we land in terms of should we or shouldn't we be doing certain things with our patients. What is the guidance? How does the literature guide us in how we should be treating patients? We start with what's called a PICO question. You look at the population, the intervention, and the comparators, and you look at the outcomes. So our group right now with the AARC is working on our PICO questions. So in this particular question, as an example, we're looking at patients in acutely hospitalized patients that are ventilated for 24 hours. That's our population. Should the spontaneous breathing trial be conducted with or without inspiratory pressure augmentation? That's the intervention and the comparator. So the intervention being spontaneous breathing trials with inspiratory pressure augmentation, and the comparator is without. Now we don't have outcomes here, but let's just assume for the sake of argument that the outcome in this PICO question is ventilator liberation. So question 2 in this clinical practice guideline was trying to answer was, again, those acutely hospitalized patients. It kind of gets repetitive when we're talking about the same thing. Do protocols attempting to minimize sedation compared to approaches that do not attempt to minimize sedation impact duration of ventilation, duration of ICU, and short-term mortality? So you see that we have comparators, the sedation versus no attempts at minimizing sedation, and our outcomes in this question are duration of ventilation, duration of ICU stay, and short-term mortality. That is high value. That's a great PICO question because we're really interested in those 3 things when we're talking about outcomes. They're called high value outcomes. In question 3, high-risk patients that are receiving mechanical ventilation for 24 hours have passed an SBT. Does extubation to preventative non-invasive versus no non-invasive ventilation after extubation lead to favorable outcomes in terms of extubation success, meaning that they were off the ventilator for greater than 48 hours, duration of ICU stay. Again, these high value outcomes. And here's the summary of the recommendations from CHEST and ATS. For acutely hospitalized patients ventilated for more than 24 hours, they suggest that we should use 5 to 8 centimeters of water pressure for pressure augmentation during spontaneous breathing versus TPIS or CPAP. That's a conditional recommendation with moderate quality of evidence, and essentially what that means is, this is probably how most people should be doing it, but there's not a ton of evidence. Usually it's going to be low quality evidence, moderate or high quality of evidence. So this is kind of middle ground in terms of how much evidence we have to support this. And I will say that our respiratory therapy colleagues in Toronto would argue that this is probably wrong because they conduct their SBTs without pressure support and without PEEP. Now that may shock some of you, but that is the way that the rapid shallow breathing index was studied. That's where it comes from. It was the research was done on 0 pressure support. And I've heard respiratory therapists argue for a very long time that, it's unfair to let them breathe through a straw for that long. But guess what? It doesn't change outcomes. So it's probably okay to have patients on 0. That's why these are clinical practice guidelines and not hard rules to live by. But generally speaking, we're going to see patients getting pressure augmentation of 5 to 8 centimeters of water pressure. For acutely hospitalized patients ventilated for more than 24 hours, they recommended that protocols to attempt sedation be utilized. Conditional recommendation based on the fact that there's a low quality of evidence. We probably need to have more research done in the area of weaning sedation. And so there's just not that much evidence. It doesn't mean that it's not good evidence. It's a conditional recommendation that, and again, the SCCM still says, let's pair our SBTs with sedation wake trials. For patients at high risk of extubation failure, have received mechanical ventilation for greater than 24 hours, who have passed SBT, they recommend extubation to preventative non-invasive. That's a strong recommendation. So we went from conditional to strong recommendation. So they strongly recommend patients who are at high risk. So this is an assessment that takes place before extubation, that this patient's a high risk extubation failure. You already know that going into it. You should preventatively put them on non-invasive, and there's a moderate amount of quality of evidence to support that recommendation. So moving on to the companion paper. Again, you see the lead author on this is Dr. Tim Gerard. There's some other familiar faces in this group, including a couple of the physicians here at Penn. And this is looking at a couple of different questions. So the first one I said was published in CHEST. The second paper, the companion paper, was published by the American Thoracic Society. And the first PICO that they had was looking at these patients. Should they be subject to a rehabilitation directed toward early mobilization? So I am a big proponent of early mobility. We could do a whole nother hour on early mobilization, and the comparator is no protocolized attempts at early mobility. Should patients that were on ventilators for greater than 24 hours be managed with ventilator liberation protocol or no protocol? Should a cuff leak test be done before extubation? And question 3B, so this is two parts to this question, should systemic steroids be administered to patients who failed a cuff leak test before extubation? Now, regardless of what I say after this, primarily because I can't remember what the next slide says, but no matter what I say after this, let me say that, and for those of you that worked in intensive care during COVID, you may have seen this as well, especially in the first wave of COVID, not maybe a little bit less in these last couple of variants, but definitely in the first couple of patients that we intubated here had an incredible amount of upper airway swelling. A lot of really thick secretions that could not be managed very easily. We had to extubate at least one patient to re-intubate them. We probably had more patients die from airway obstruction than we know. I know that the very first code that I watched, I wasn't involved in, a colleague was, but I was outside the room helping. The patient coded, and the first COVID patient that I saw code and die. I'm 99% sure that their airway was obstructed, and we just didn't know. And by the time we figured it out, it was too late. So these two questions here, high recommendation in terms of COVID for doing a cuff leak test. And also a high recommendation for doing systemic steroids for 24 hours after a cuff leak test has failed in COVID-19 patients. So in terms of answering the three or four questions from the ATS guidelines, they suggested protocolized rehabilitation directed towards early mobility. It's a conditional recommendation with low certainty of evidence. I know that the reason that that is because the only randomized control trial that has been done for early mobilization was done by one of the co-authors of this paper, Dr. Bill Schweikert, when he was in his fellowship, and it's an excellent paper. Physical therapy quotes that paper almost as gospel truth, and here we see that the ATS agrees that we should be doing early mobility with our mechanically ventilated patients. The ATS also recommends that patients be weaned using ventilator liberation protocols. Surprise, surprise. However, there's a low recommendation because it's conditional recommendation because of a low certainty of evidence. So in all of these areas where there's low certainty of evidence, we should be gearing our research toward answering these questions more thoroughly. So the ATS also suggests that the patients ventilated that are deemed high risk for extubation, stridor, should have a cuff leak test done. So again, this is something that you can kind of assess prior to. It's not every patient, not every single patient needs to have a cuff leak test done. Again, conditional recommendation because there's a very low certainty of the evidence of need for cuff leak tests. And I will tell you that we do not routinely do cuff leak tests. Although, like I said, we did and continue to, if we have them, do cuff leak tests on patients with COVID. And for patients who failed a cuff leak test, they say that administering systemic steroids for at least 4 hours after extubation is appropriate with modern certainty. So it's important to note that this is almost like a conflict of interest statement at the beginning of a presentation, right? Neither of these guidelines is intended to impose standards of care. This is a direct quote from the papers. They provide a basis for rational decision making and liberation of patients from mechanical ventilation. And so I think that's an important statement to make because I think that what we are seeing, I think, this is my opinion, that I think what we're seeing is a more individualized approach to our mechanically ventilated patients. We can't all be like cut and dry, bread and butter, black and white, whatever analogy you want to use. Not every patient's the same, and so not every time we liberate a patient from mechanical ventilation should it be the same. So I'm going to move in the direction of like kind of assessing patients for readiness, a spontaneous breathing here. We talked about the evidence a little bit. Early on in this presentation, I noted that there are certain criteria that need to be met in order for a patient to be ready and safe for a spontaneous breathing trial. So those things included no agitation, oxygen saturation of greater than equal to 88%, FiO2s less than or equal to 50%, PEEP of less than or equal to 7.5, no myocardial ischemia, no vasopressor use, and inspiratory, and they actually have an inspiratory effort being made. Before I get to the point of this slide, I just want to pause and note that in terms of FiO2 and PEEP, I think that sometimes clinicians get hung up here. I've seen documented in charts that the patient was not ready for an SBT because they were on 50% of oxygen concentration and they were on a PEEP of 7.5. So what's the problem? Well, this guideline, the guidelines that we use in my institution say less than or equal to. Less than or equal to means that it can be equal to 50% and your PEEP can be 7.5. And even in your morbidly obese patients, you may even see your PEEP a little bit higher than that, and a patient is still eligible for spontaneous breathing trials. We shouldn't let these things limit us too much in terms of when patients are ready for spontaneous breathing. But these aren't, you know, if a patient's on 50% FiO2 and a PEEP of 7.5, or even maybe slightly higher depending on their body habitus, they may still be ready for spontaneous breathing. Now that wasn't the point of the slide. The point of the slide was to point out this 2022, just published back in February, I believe, retrospective cohort in the Blue Journal looking at vasopressor use. So you notice here that it says no vasopressors are used when a patient's ready for SBTs. But one of the conversations that I've had with Dr. Fuchs about this is maybe we limit patients to their ability to wean from mechanical ventilation if they're on a certain dose of vasopressor. Now, I'm not saying that this is somebody that's in 3 pressor shock and they are still very, very septic. No, this is patients on lower doses of vasopressor, and I didn't necessarily put up the dosing here because that's not the part that we're interested in, but you know, it's low dose vasopressor. Now this they looked at a big group. It was like 6,100 patients, and 721 of those patients, only 12% of the patients were extubated while receiving vasopressors, and 5,400 patients were discontinued, were extubated after vasopressor was discontinued. I suspect that's because of this recommendation, but you know, could we potentially extubate more patients sooner if we allowed for low dose vasopressor to exist while the patient's on mechanical ventilation still and being extubated? So the primary outcome of this was reintubation within 96 hours. So in a population of acutely ill patients that have been on ventilators for a certain period of time, they go through SBTs. That's kind of your PICO question here. The primary outcome that they're looking at, did they get reintubated within 96 hours if they were on vasopressors when they were extubated? So extubation on low dose vasopressors was associated with lower mortality. That's fantastic, and that's statistical significance, right? And they had shorter ICU lengths of stay if they were on low dose vasopressor. However, there was no difference in the reintubation or hospital length of stay as compared to those that were weaned off vasopressors prior to discontinuation of mechanical ventilation. So, you know, ICU length of stay decreased. That's a good thing. That probably means that mechanical ventilation was not delayed because of the vasopressor. But look at this, still 5,400 patients were not extubated until after vasopressors were discontinued. So it will be interesting. This is a 2022 retrospective cohort that was published in the Blue Journal, like I said. Now think about it, those ventilator liberation guidelines that I shared with you earlier were published in 2017. So, you know, we have this 5-year spacing in the literature. It'll be interesting when the ATS and CHEST go back and revise their guidelines in the future, that potentially vasopressors are looked at as maybe getting patients off the ventilator a little bit sooner. So I mentioned the rapid shallow breathing index earlier in a presentation. The CHEST just published a systematic review and meta-analysis. This means that a team of clinicians did a thorough review of literature, and they analyzed all of the data. So meta-analysis means they took all of the information, all the data from whatever number of randomized control trials that they found, and combined all the data to make to produce one big mass of data that that you can rely on, reliably quote for whether or not something is evidence-based. So we're looking at rapid shallow breathing index, systematic review and meta-analysis, one of the highest form of evidence-based practice, and they're answering the question, how well does RSBI predict success of extubation? Well, you know, they started off with a certain number of studies. Usually that number is in the hundreds or even thousands of papers that the team looks at, and they distilled that down to 48 studies that combined 10,946 patients. So you can see, like, a randomized control trial might, whereas a randomized control trial might include just a couple of hundred patients, a systematic review of meta-analysis usually has patients that numbers in the thousands or tens of thousands of patients. And here we have nearly 11,000 patients that identified, and we look at the sensitivity of RSBI. So we know that RSBI should be less than 105 and we usually look at that as a prediction of extubation success. But the sensitivity was moderate. There's a moderate certainty when you look at these data that the sensitivity of RSBI could pick up somebody that was going to succeed or fail at extubation. But what's really important is specificity. So you can say that something is super sensitive, but the specificity can be very poor. And what we find here is that in the conclusion of this systematic review and meta-analysis, the RSBI thresholds of less than 80 or 80 to 100 yield similar sensitivity and specificity. Gosh, try to say it 10 times fast. And that means that even though you could theoretically use the RSBI as a predictor of extubation success, it isn't specific enough to actually say, yes, this is what we should be using regularly. And I will be honest, I haven't looked at the RSBI as a predictor of extubation success probably in about 5 years. Now, once a patient is extubated, the post-extubation care of a patient still leads toward liberation. Non-invasive ventilation or high-flow nasal cannula. Should we be extubating? You know, we know that the recommendation came that non-invasive should be used for patients that are at high risk of reintubation, but should we be using non-invasive ventilation or high-flow oxygen therapy? And this was looked at some of our by the European Respiratory Care Society as well as the American Thoracic Society. The recommendations from this clinical practice guideline was suggestion that non-invasive be used to prevent post-extubation respiratory failure in high-risk patients, as we saw in the previous in the previous clinical practice guidelines, again, conditional recommendation, low certainty. We need more evidence to support this recommendation. They also recommend that non-invasive should not be used in post-extubation respiratory failure for non-high-risk patients. Now, I will say that the one exception to the rule to this guidance is probably COPD patients. So respiratory failure that's due to COPD might likely want to use some non-invasive ventilation post-extubation. That's not in this guideline. That comes from other data, but I'm just pointing it out to say that, like, don't conflate ventilatory failure with oxygenation failure. If a patient is failing oxygenation, as far as oxygenation goes, there are other things that we can use, such as high flow nasal cannula, to treat that. There's a randomized control study published by Fratt and his colleagues, 2017. 204 patients with respiratory failure were admitted to emergency departments that required non-invasive. 39% of those patients had COPD. The primary outcome of this randomized control trial was whether failure rate was defined by the need of intubation or decision to apply alternate therapy within 72 hours. The results showed that high velocity nasal insufflation, that's a fancy way of saying high flow nasal cannula, was 7%, and that non-invasive positive pressure ventilation was 13%. So that's statistically significant. In the conclusion of this randomized control trial, they said that tolerance of high flow oxygen therapy appeared to be higher than tolerance of non-invasive. That makes a ton of sense, because I would think that high flow is more comfortable than non-invasive, personally, if not for the barrier of the mask. And the effect on PCO2 over time was similar throughout the entire study population. So CO2 didn't really change when comparing high frequency oscillatory, or excuse me, woof, that's not where we're going with this at all, with a high flow oxygen therapy versus non-invasive. In terms of monitoring, another recently published randomized control trial from our friends at Rush University in Chicago. This is actually published online ahead of print in Respiratory Care. You can find it there now. 117 patients in each group. One group receiving a standard respiratory assessment. The control group, an automated monitoring alert was sent out to clinicians to say, hey, you should assess this patient after they're extubated. In the intervention group, there was no statistical significance in intubation of either group in 72 hours or at 7 days. So in this study, they found that there was no significant outcome or cost differences between a standard RT assessment tool or an automated monitoring alert to initiate respiratory driven care. And I will say that as somebody that works in an institution where these automated alerts have been utilized in the past, now we have our telecritical care respiratory therapists and nurses monitoring our patients. So it's kind of it's a slightly different way of approaching it, but the use of automated continuous monitoring to alerts to initiate respiratory assessments and treat protocols reduced the amount of time that RT spent providing care in this patient population. So again, this was just published in March online ahead of print. So you could go to Respiratory Care Journal and read that now. And with that, my time has come to the end, and I would be happy to take any questions that you have.